collection together, and lots of Mazel Tov as well. Mazel Tov to Albert Singer, as you mentioned earlier. It's his 83rd birthday, second bar mitzvah. He's meant to be in Australia to do this, but Albert, we're here. We're welcome. Very happy to have you with us for this week and always. And Mazel Tov to you. And you would have done Haftarah in shul this week, we know, but you'll definitely do it next year. So wonderful, and Mazel Tov to you. And tonight we have Doctor on Doctor. We have a very interesting, great event tonight. Dr. David Stone's going to be interviewing. As you know, David was a consultant cardiologist and a medical director of the Papworth Hospital in Cambridge. But even more important than that is that he is the head of the Central Square Minyan Medical Committee. And tonight he's going to be interviewing Dr. Claire Lemer, who's also a good member of our community. And David's going to introduce Claire and ask us some very interesting and, I hope, challenging questions. So over to you, David.
Right. You can all hear me, I hope, in my first host. I've admitted a few people, so I feel really into it. Claire, we put a fairly minimalist description of you, consultant paediatrician and clinical director at the Evelina. Perhaps you could say a bit more about what you've done in the past and what you're doing now, just to introduce everybody and get them in the...
Sure. First of all, I just want to say a big mazel tov as well on a second bar mitzvah. That's an amazing thing, Albert. So a bit about me. So I am a consultant paediatrician. I've been at the Evelina, which is a children's hospital that almost no one has ever heard of. It's the second biggest children's hospital in London, and a little bit different from Great Ormond Street because we have an A&E. So children come from all around London, in fact, all of South England, to us, both through the emergency department and in other ways. And we're nestled within the bigger hospital of Guy's and St Thomas's. So you can be looked after us as a baby, a neonate, all the way through to 16 and sometimes a bit longer. And then we hand you over to the adult hospital. So we really live the NHS mantra of cradle to grave. And we have, and that means we serve many different sorts of populations, one of which is our local population. We're based in Lambeth, so we look after children primarily from Lambeth and Southwark, but we're also a tertiary hospital, so we take referrals from, as I've said, all across South London, South England, and for some things for the whole of England. So we are a big children's hospital. It's just that most people haven't heard of us yet. But we're about to start a big building programme, so I'm sure you'll hear more about us when we start asking for money and showing people pictures of our shiny new buildings. And the Evelina name, this audience will appreciate this, comes from Evelina de Rothschild. The original hospital was founded by her husband after she died rather tragically, just after giving birth. It was a little hospital not on the current site. It was halfway between us and Guy's. And in 1948, when the NHS was created, that hospital was incorporated into the Guy's children's wards, and the name disappeared. But when the decision was made about 25 years ago to build a children's hospital on the St Thomas's site and move things from Guy's there, the name was resurrected, and that's why we are the Evelina London. So I've been a consultant there for coming up for 8 years, and before that I had a maybe unusual career in that halfway through my training as a paediatrician, I spent a year in the States doing a policy fellowship and became very interested in how policy around health is created and also in public health. And so I came back to the UK and carried on my training for a little bit, but then I ended up working at the Department of Health. And I did that for nearly 3 years, although during my time at the Department of Health, I spent half my time working on health issues in the United Kingdom, including things around patient safety and other issues. And then I also worked for the World Health Organization, again, primarily on patient safety issues. And they covered everything from children's health all the way through to things to do with radiotherapy, for example. After I finished my time at the Department of Health, I did a stint in consultancy, working for one of the management consultants. That taught me a lot. And then I did something that's relatively unusual still for a doctor. I started to continue my training, but part-time. So half of it I did in Barnet and Chase Farm, and the other half of my time I worked as a service manager, so on the operational side, the administrative side of a hospital. And I did that for 2.5 years. So I ran the ophthalmology department of the North Middlesex, and I did some work as well in the postnatal. And then I went to Northwick Park and finished my training at Northwick Park, and then I moved to the Evelina, where I've been for 8 years. And I've done a variety of different roles alongside my clinical role. So my clinical role means I see patients. Oh, can people not hear or see me? David, can you see and hear me?
I can see you and I can hear you. It's slightly blurred, but not very poor.
Okay.
So I think you're okay. Does everyone else?
I'll keep going. Oh, okay, good. I see some.
It's not filling your screen.
I'll keep going. I forgot where I got to. Oh yes. So I have so for the few years I was involved in setting up what we would now call an integrated care system for children. It's really the only one in the country, and that's where we tried to pull together GPs and hospital paediatrics so that it works in a much more flawless way, and to do that in a very proactive way. So in essence, what we do is we screen populations of children for diseases like asthma and eczema, and we proactively get involved with them before they seek care. And in doing that, we've managed to reduce admissions to hospitals. And then I started to also get involved in medical management, and that's how I come to have the 2 titles I have at the moment, so general pediatrics and also as the clinical director. So the clinical director means I look after 22 services. They cover everything from urology with a U all the way through to neonatology. We have a turnover in my bit of the hospital of just over 100 million, and that's about just over a third of the hospital's turnover. And we deliver everything from really innovative surgery, deep brain stimulation, which helps children with fixed muscle deformities, all the way through to premature babies via, as I said, general pediatrics, which serves the local community. It's a job I love, as you can probably tell, and I'm very privileged to be doing it. Sorry, that was a very long introduction.
Thank you. You've got the job. It is fine. When all this COVID came along, what was your most useful attribute in your terms of your experience, not your personal attributes? Help you deal with this? Did you see it coming? Did the hospital understand what was about to happen? After that, we go down to the individual patient and work it outwards if we can.
Sure. So one of the things that is an enormous privilege about working at somewhere like Guy's and St Thomas's is that we have specialists who are not just local specialists and experts or national, but some of them are international specialists. And as a result of that, Guy's and St Thomas's is one of 5 hospitals in the UK that takes contagious diseases. We have all the setup both for children and adults. So as I'm going to keep, I can see people putting messages in the chat, but unless David tells me that you can't see me or things are not working, I'll keep going. I'm sorry if people are struggling. So what that means is that we started seeing patients with COVID very, very early on, sort of late January, early February. So we were already starting to get into the sequence of events that you need to manage them. At the time, we tended to be seeing well patients, but we were isolating them to try and prevent what eventually happened, which was this became an epidemic and then a pandemic. So we started to think about COVID very early on, I would say. And I will never forget a meeting, as someone put it to me rather beautifully, in the time of gathering. So we haven't had meetings like this for a rather long time. It's not a Zoom meeting, where the clinical directors from all across the hospital, heads of nursing, managers and the executives sat in a lecture theatre, and we were talking about the trajectory of this strange disease and what might happen and so on and so forth. And the reason I'll never forget that was because our intensive care unit doctors were saying, we need to start thinking about stopping doing things so that we can cope with the number of patients we're likely to see. And so we started to talk about reducing the elective work, whether that was outpatients or surgery, by 50%. So remember, this is late February. And eventually the chief executive could sort of sense that there was a kind of mumbling of disquiet in the room. And he looked at everyone and he said, what are we thinking? Are we thinking that's the right speed? Are we thinking that's too much? Are we thinking that's not enough? And almost without a single person disagreeing, every hand went up and said, do more and do it more quickly. And remember, this was before we were in the kind of reality of where we are now, where we have been for the last almost a year. So I think we were lucky to be thinking about this, but then the reality of what that meant then happened. I spent a week locked in a room trying to work out how you safely stop elective surgery or stop elective outpatients, because you can't just decide and send everyone a text message and say thanks but no thanks, because some of those children are really dependent on the hospital. It might be because they have dialysis, it might be because they have a condition that's deteriorating. And we had to work out systems and we had to work out governance to make sure those systems were safe, and we had to get into new habits. So we were very lucky to be slightly ahead of the curve. We were also very lucky that the scale of the hospital, our turnover shortly will get to over 2 billion as a whole hospital. So Guy's and St Thomas's, when it is linked with the Royal Brompton. And that means that we can do things at scale. So we saw in advance we were going to have problems with oxygen flow. So we had engineers and actually the army come in very early and help us boost our oxygen flow. You can't do that if you're a tiny hospital. You're not going to get that kind of uptake. When it came to PPE, there were times when we ended up having to order in our own, and the same with scrubs. There was a hilarious discussion amongst the heads of nursing about what colour scrubs should be decided on, and then a bit of argy-bargy whether or not the colour, which was teal, was actually teal, or whether or not it was green, and that went on for days, which was light relief in the midst of chaos. So scale has definitely helped.
Okay, so I was reading about the 1918 pandemic, and it was different in some ways in that a lot of young 20 to 30 people died in that. It was a flu pandemic, so there were different symptoms, but a lot of the children that died, they weren't sure if they died because of the starvation or hunger caused by the death of all these very young parents, or whether the kids had much of the disease themselves. And one of the recurrent statements about this particular pandemic is that children are okay, we can let them get on with it more or less, including schools that we'll come on to. So is that your feeling, that the kids are indeed, I won't say immune, but something we should worry less about? Or are you seeing a lot of both primary, i.e. due to the disease, and secondary, i.e. due to the other stuff you mentioned, not coming in for surgery or for links with their nursing staff or whatever that are supporting them through complex diseases?
So it's been quite a fascinating year in terms of what we're seeing. So we had seen in our emergency department year-on-year growth. Between December 2018 and 19, we saw a 25% increase in visits to the emergency department. We're now at a third of what we were seeing a year ago. And partially that's because obviously people being in lockdown means that bugs don't get spread amongst small children, and so they don't come in with infectious diseases, but they also don't come in with some of the corollaries of that. But with COVID specifically, we have not seen vast numbers of children, and definitely not following the same levels that you would expect if you correlated levels in adults or older people to children. And the children that we have seen, we've seen tiny numbers of children who've needed intensive care unit support, almost all of which have had underlying other illnesses. We don't really understand why the coronavirus doesn't affect children in the way that it affects adults and older people. There are lots of theories, but I think it's too early to say. So we're not seeing that. what we did see, and we started to see it 4 to 6 weeks after the first surge began in adults. So we've done modelling, and we're expecting, if we're going to see the same thing, it will happen in a few weeks' time. We did see something which is essentially a delayed reaction to the virus, where your body is fighting the virus, and that causes all sorts of unfortunate side effects. So these kids present with a range of symptoms. It can be abdominal pain, it can be rashes, and what was completely fascinating was, for reasons that are unclear, a large proportion of the cases happened in South East London. And so our infectious disease team and our intensive care team were seeing these children and started to contact other hospitals and started to send out alerts, and more importantly started to try and work out how to treat it. So one of the really fascinating roles I've had is corralling different medical opinions and trying to get consensus so that we could actually come up with treatment plans that could be followed generically, both in our hospital but also across the region, across London and the UK and beyond. And that's very hard when you've got a new disease and you're trying to work out what the best treatment is real time with actually managing these kids. And also it's hard because we wanted to enrol these children in studies as well. And that's been one of the extraordinary things I don't think we've talked enough about in the NHS, how many people have been enrolled in studies, which have been really crucial to the fact that we are now able to treat both adults and older people with treatments that have been through really rigorous trials. So we managed that in the first wave, and we now have quite a slick system, at least in South London. We have teams set up who can do the things like echoing children very quickly. Children come in, they have an echo, some of them go home the same day if the levels of various blood markers are okay. If we think they're more unwell, they come in and stay. We have a daily call with the region so we can check in on all of these patients. Thank goodness for Zoom and Teams. And we have protocols and guidelines and trials set up so we can test that. So I think that's a real credit to the resilience and the really intelligent way that people have gone about this, but it's not been without its challenge. Writing a guideline and disseminating it is hard enough at the best of times, but in the middle of a pandemic, when people are distracted by other things, it's even harder.
Okay, so moving on slightly to the community, because obviously a lot of what you do is in the community as well. Two parts to the question. One, NHS service, National Health Service, as it were, seems to me to be wonderful in general terms, and really achieving something that perhaps I don't like to compare countries, and I don't think we should, but compared with another country such as the United States, which has less coordination between all its various parts. Do you feel that is a correct statement? And two, when it comes to schools, which again has been a big issue around COVID, letting the kids back to schools, how much have you been involved in that, and what has your involvement been, if you have been involved?
Okay, so I'm amazingly proud of the NHS. I've spent quite a lot of time in the States, both looking at how hospitals work, but also looking at health policy. And the more time I spend away from the NHS, the prouder I am of it. It's not perfect, but the commitment to it and the sense of trying to achieve equity of access, at least for everyone, regardless of who you are and what you bring, is really, really important. And I think speaks to the values of many people who work in it. So have we done this perfectly? No. Are there going to be many commissions and inquiries to try and work out what we could do differently? Yes. I really hope that one of the things that comes out of this is an even stronger public health system. Public health was integrated to a large extent into the local authorities, and I think we need to think about whether or not that's worked and how we coordinate. But I also hope that something else comes out of this, which is around trying to bring the same sense of unity and cohesion that exists in the National Health Service to social care. And for those who've heard of the Dilnot review, that was an attempt to work out how we pay for that. And I really hope that in the same way after the challenge of the Second World War, the NHS was set up I really hope we can find a way to do something similar with social care, because it's the next big frontier. So David was alluding to the fact that I'm a chair of governors of 2 primary schools in Peckham, and I also am involved in the Jewish Community Academy Trust, so the multi-academy trust that looks after 5 schools for the United Synagogue in North London. So for those who don't know what an academy trust is, it essentially means that various governments have decided that it's more effective to group schools together in ways which don't involve the local authority. So essentially we act as the coordinator across those schools. And the schools I'm involved with in Peckham are part of a different multi-academy trust. That one is called the Harris Federation. And so it's been fascinating for me trying to understand or look at those 2 different setups. So Peckham, demography obviously different from North London, huge numbers of children who need support, both from a social care perspective, but also from a language perspective and from an income perspective. And so one of the things that we worked on a lot was trying to get remote learning to those families. If you're a single parent family living in a bedsit with dodgy Wi-Fi or no Wi-Fi or no computer, or the only computer is the one that your mother or father is using for work, that's very, very different from a family perhaps in North London. So we supported families by giving them access to laptops, iPads, dongles, so that the children could get access to learning. But also, learning's great, but you can't really learn if you're hungry. So even before the whole school meals voucher began, we were supplementing the existing resource and giving out vouchers to children, or rather to the families in the area who needed them. And alongside that, one of the other things that we really mustn't forget is the social care aspect. A lot of the children in those schools are on social care lists for being vulnerable for various different reasons. And so the teachers did an amazing job of making contact with each of those children on a weekly basis to check that they were not suffering from too many ill effects of coronavirus. In North London, in the MAT I'm involved with, absolutely some of the same issues that I've just described, but there was definite benefit from the community. Some of the community trusts were amazing in supporting meals and other things for children and their families. And I think the response of the teachers in those schools and the head teachers was incredible, in particular, switching almost overnight from face-to-face to online, and also, again, supporting families, reaching out to them. And one of the things that's completely true of the NHS and schools is one of the biggest challenges is when staff start to get sick. So the benefit of having a multi-academy trust in North London was we could move teachers around, and that was particularly important because there were some kids coming into schools, more in North London than the kids I'm involved with in South London, who were key worker and family children, or especially now it's actually as many vulnerable as key worker families. But in the first lockdown, it was mostly key worker children. So it was important to be able to flex and have a hub where we could do that.
Great, thank you very much. We're getting a few questions in, some direct to me, one from another family, Stone, who I know quite well, asking about the impact of it all on children's mental health.
I think that's a great question. We have definitely seen an increase in the number of acute mental health presentations coming to our emergency department. They didn't come during the first lockdown, they came just afterwards. Interestingly, a lot of those children were children who had learning disabilities. We definitely saw that. One of the things we did in our emergency department to try and relieve the pressure in the rest of the hospital was we started taking children up to 18 and sometimes even beyond that, so young people. And we definitely saw a lot more mental health problems amongst that group. And that created all sorts of logistics issues because there are still shortages of inpatient beds, and community teams were obviously struggling during lockdown and COVID. So juggling all of that has been difficult. But I think that's going to be part of the long tail of COVID, is the impact on mental health, both for adults and children, and to be fair, also staff in education and in health.
Right, thank you. Another question. It's been half an hour or so, so vaccination was due to come up at some stage. This is from Judy and Ben Tobin saying that some countries are vaccinating care workers and economically active before the elderly. I know it's the other end of your age spectrum, but do you have a view on that policy?
So I think there are a huge number of really difficult decisions that have been made during this pandemic. And I think we're very lucky in the UK that we have the Joint Commission on Vaccines, who have provided the ethical framework and the decision on which groups go when. And I think it's really important that we support their really careful thinking. But I think we should really also remember that as big as the decisions over vaccination are, there are decisions being made at all levels, at all times during this pandemic, which are really challenging. These are not just about who gets admitted to intensive care units, because we've been very lucky that we've been able to surge our intensive care unit capacity. My hospital's at more than double, shortly to get to triple its adult intensive care capacity. So it's not so much about that, but it's also about the fact that in order to do that, we're having to change access to, as I said, elective surgery or elective treatment. And there's a constant juggling and balancing of making sure that those who need those services get it. So that's just one of the many, many difficult challenges that many people, from policymakers to frontline clinicians, have had to face.
At least they're trying to make them. I mean, there are further questions about teachers and children. Do you think they should be vaccinated? I won't say yes or no, but
so children are an interesting question. One of the challenges with children is that the current trials that have been done haven't involved children, and that's because the ethics of involving children are quite complicated to do at speed, and so they didn't want to hold up the trial. I think what we'll probably see is that as time goes by, the age threshold will drop from 16 to 14 to 12 to so on, and then as more data comes online, we'll extend the vaccinating. But it's a really difficult challenge, because obviously we want to allow as many people and as many children as possible to be vaccinated, but we also don't want to put people at risk without evidence. So I think it's a constant juggle. And that's not based on vaccine shortages or vaccine logistics, that's simply based on trial output data.
Okay, thank you for that. Now, one final question before we opening it out to the general open questions, and that is from Martin Curzon. It's reflecting what we're all thinking, really. He says, how do you manage to juggle your clinical and administrative role? And I know you haven't mentioned your most demanding administrative role. Which is, he says, how do you manage? We're all saying, how on earth do you manage to do all?
So I think a number of things. Working in really great teams where you can rely on others to do things is really important. I think I've come over many years to accept that perfect is the enemy of good enough, and being very pragmatic about these things. I think also having amazing family and friends who are incredibly supportive in all sorts of ways, whether it's my parents who were safely shielding, coming on a big adventure to rescue me the day that I managed to lock my car key in the car outside work. They drove down, threw the spare car key at me, and then drove off again. So whether it's that kind of rescuing, or the people who very sweetly leave soup or other food parcels on my door step. So it's a combination of those things. But I think actually, in many ways, I do think that if you get to do lots of different things, you bring the learning from them across. So, it was helpful that I could pick up the phone to some of the head teachers every time they had a COVID issue and explain to them what my thinking was. And similarly, it's really helpful to get a sense of one of the reasons why I'm governor of schools in Peckham is because I don't want to just see the children of my local area when they're sick. I want to understand a bit about what their normal lives look like. So it's helpful to have those crossovers. And I try and keep a little bit of time for me, with a bit of running. So some of you will see me in my fluorescent outfits running about the suburb. I've learnt my lesson from a few years ago. I'm very, very well lit up when it's dark. and I stick to the pavement as much as I can. So it's not all juggling. There is a little bit of time for doing other things.
Even listening to opera.
Even listening to opera, exactly.
Okay, good, very important. Well, everyone, Edward, I hope is going to open it all out to everyone. For if anyone's got any question. From my point of view, Claire, that's been brilliant. Gives everyone an insight into what it's really like to work within the system as a worker, rather than just look at the figures that are trying to reflect what's going on. So brilliant, thank you very much for that. Edward, over to you now.
If there are one or two more questions, we do have some time. If people can unmute and ask, do go ahead.
Claire, what's your feeling on schools and primary schools in particular, when we know that children are much less at risk themselves and that they don't seem to transmit as quickly as adults as well? I'm very fearful for children's education at such a vulnerable stage.
I mean, I think looking at the kids in Peckham who came back after the first lockdown and talking to the head teacher, she felt that this challenge wasn't just with the educational side of things. So it wasn't just that the kids hadn't learned what they perhaps would have done in that previous year. It's all that it's also, to someone's earlier point, the developmental side of things. So the social interactions for the very early years, even simple things like toilet training and things like that had not moved forward. So I think there's a massive challenge that we're going to face when we get to reopen and move on. I think it's such a complicated juggle because the teachers are rightly worried about the impact on them and how to keep them safe. And even if you do open schools at the moment, obviously you can't legally, but even if they were, teaching across a 2-meter barrier or so on and so forth, even within a bubble, is really, really difficult. That's not how most teachers want to teach. They want to sit with the kids. They want to be involved in the kids. So I hugely worry about this. And I'm just talking about primary schools because they're the schools that I'm involved with. But there are similar issues, and then the mental health issues that flow into secondary schools. So there's going to be a lot of unpicking to do. I did listen in on a conversation with head teachers this week and chairs of governors, and one of the things that they wondered would be a good thing that came out of this is whether or not GCSEs actually need to be the way they are. If you look at colleagues abroad, in places like Canada, they don't do any formal exams until 18. So, maybe we'll move to a system which stops this continuous testing and see whether or not that changes things. So maybe there's a silver lining, but at the moment, I agree with you. There are lots of challenges, and I think time is going to unearth some of the consequences, and we'll look back on this and prioritise or put into a different level of hierarchy some of those effects.
Right. Any follow-up to that one? Albert, yeah.
Claire, first of all, congratulations. That's about the only word you can use for it. You have a very multiracial and diverse society, multicultural, multiracial, down in South London. How do you deal with it? Because just hearing at the moment that some of the South Asian community have their own ideas on the ill effects of being immunized. How do you go about, dealing with them? You've hardly mentioned it because that must be a tremendous problem to you.
Yeah, so that presents itself in all different ways. So obviously, particularly during the first wave, we had a lot of staff who were increasingly fearful because they were in some of those high-risk groups. And so we did a lot of risk assessments, which takes a huge amount of time, but it's really important. And then we had to work out where people could work and sometimes move them about to try and protect them. And similar things were done in schools. But in terms of vaccines, one of the things we're doing at the moment, because you're right, even amongst staff, So we're vaccinating, we're a vaccine hub. We currently have 4 centres open at St Thomas's and Guy's, and we're vaccinating older people and also staff. And amongst staff, the take-up is not equal across different ethnic groups. And so one of the things we're doing is we're running a lot of Q&A sessions, we're running a lot of information sessions, and we're trying to do that with people who understand some of those challenges talking. So I've been helping to put together a panel of people from BAME, so doctors, nurses, midwives, local church leaders, and so on and so forth, who can try and address some of the questions that people have, because misinformation spreads like wildfire, and it's really hard to counter that, but it's really important. Otherwise, we'll see continued inequity in both access, but more importantly, in disease incidents, because people are not vaccinated.
Thank you.
Thank you. Can any Robert Winston, I see waving. You're muted, Robert.
Just thought I've got to use this kind of platform by now. So I use it all day, every day. I just wanted to interject on a very important point that Judith raised, which is the issue of the. Sorry, you've got an echo. Could you turn your? Sorry, thank you. My wife and I are operating separate computers for strange networking reasons. But basically, sorry to whitter. The interesting thing is that there's a question of socialization of children, and I agree completely with what Claire's saying, and also the very interesting question that Judith raised. But I think we could afford to be a bit more optimistic, perhaps, because when you look at the studies of the Romanian children that were brought up in the most appalling circumstances at the time of the revolution, and there are some very, very good long-term studies on those kids now, unless they were in very severely deprived circumstances, and then only a minority of them actually showed serious issues within a few years of actually being back in a reasonable environment. So I think we might find that these primary school children are a little bit more resilient in the long term, providing they're then given sufficient support. So whilst I agree completely with what's been said, I think it might be helpful to be slightly optimistic, but of course we're going to have to encourage that optimism by doing the right things with those kids.
No,
do you have a comment on that, Claire?
I think that's very fair, and I think it's important to think about the resilience across the whole system. I mean, one of the things I find absolutely incredible is we've given over more than half of our paediatric intensive care unit to adults, and that's being staffed by our staff. And when I say staffed, I mean our nurses. I have consultants going and helping with turning teams, because the positioning of adult patients is really important to improved outcomes. I have doctors and nurses and others, physios, admin people supporting those teams by doing communication sessions where they go and listen in on ward rounds and then spend the time calling families so that the families get updates regularly. So, but the amazing thing is that happened in the first wave as well, and a lot of people found that very difficult, and really didn't want to go back to doing that again now. But actually, when you talk to them and when the need was made clear to them, I can't tell you how quickly people rebounded. So I'm constantly impressed and amazed by the resilience of adults, and children are even more resilient. But I think, Robert, your point about if we give them the right support is the key thing here. And so it's going to need a little bit of thinking about. I know the primary school in Peckham, when they went back for a little bit over the summer, were doing some really nice things in the early morning. They were spending a sort of 15-minute reflective session where they were just getting the kids to talk about what was going on at home, what was going on in their minds. Some of them were doing it in talking, some of them were doing it through colouring, some of them were doing it through playing with toys, and it just gave them a little bit of time in what's normally quite a busy school day to actually be able to articulate it in a way that a child could do their response, and hopefully to help them to recover from it. So I agree, hopefully a more positive future than we might fear.
Any other questions at this stage? Wave if you, I'm scanning the no more questions. Okay, well, Claire, again, thank you so much for your contribution. I don't know what to call it, amazing sharing of how it's all going. Please keep well, everyone. I don't know if Rafi, you want to, I can see you now. Have you anything you want to say at the end before we close up?
Just, that was great. It's so wonderful to have such interesting, accomplished and helpful people in our community who are making a difference. So I'm just very thankful for that.
Yeah, thank you.
I certainly want to echo that and say thank you very much to Claire. And also to tell everybody about our speaker next week. Next week, as many of you, hopefully you all will know, is Mental Health Awareness Shabbat. And we're lucky to have as our special guest Adam Dawson, who's the chairman of JME, the organization behind Mental Health Awareness Shabbat. So we look forward to welcoming you all back next Motzei Shabbat, also at 6 o'clock. And also every Monday we have a really interesting and successful study group looking at the works of Rabbi Sachs, facilitated and led by Marcus Reed, and we would really welcome anybody else who hasn't yet joined to join. It's at 8 o'clock and lasts about 45 minutes. So please feel free to join us.
Thank you.